Dying for a Chat provides an insight into modern medicine through the exploration of the patient-doctor relationship. The author Dr. Ranjana Srivastava, a Melbourne-based oncologist, contends that as we become more medically and technologically advanced, compassionate healthcare is sacrificed. And as doctors increasingly specialise, they offer patients only a piece of the puzzle, crucially lacking an overall picture. Srivastava contends that the best medicine should begin with a good chat. The author argues that our doctors are often ill-equipped in the area of communication and patient care is disadvantaged as a result. In her declaration of an unacknowledged crisis, she prioritises the urgency for healthcare training to incorporate effective communication skills alongside medical training. The primary issue addressed by the author is the lack of emphasis on doctor-patient communication in navigating a course of action. To illustrate her point, Dr. Srivastava utilises an anecdotal but all too familiar story of Mrs. Johnson, an elderly 90-year-old widow questionably admitted to hospital from a nursing home for management of a mild chest infection. Within the acute hospital setting, we follow Mrs. Johnson through a maze of tests, x-rays and procedures, overseen by a hierarchy of medical specialists and doctors. After her IV site becomes infected and complications arise, Mrs. Johnson becomes one of the revolving suite of very old and sick patients entering intensive care when their only chance of recovery is theoretical. She develops hospital-acquired pneumonia, her kidneys and heart fail, and she is tube-fed on her journey to her inevitable death. Propelled by a multitude of specialists through the highly sophisticated, technologically advanced machine known as ICU, yet we know it is futile. At no point is Mrs. Johnson consulted regarding her wishes. In fact, end-of-life care discussions were actively avoided by many doctors at opportune points along the way. The gap between how doctors and patients and relatives perceive the unfolding event sits heavily with the reader as her bewildered children, trusting to the end, witness the undignified end of their mother's life. In telling her story, Srivastava flags the systematic public health issue of medical over-servicing, especially at the end of life. Aside from the implications for decision-making and costs, the lack of communication between specialists leads to fragmentation of care and consequent diffusion of accountability.
The ID physician wants to talk about her antibiotics, and the renal physician will only talk about her renal function. Cardiologist will only talk about her heart function, but there's nobody talking to Mrs. Johnson, nobody making the big decision.
Nowadays, patients are less likely to have a consistent primary care GP and are frequent and active consumers of healthcare, with an assumption that more medical care means better medical care. The Age newspaper recently confirmed current figures from the Australian Institute of Health and Welfare showing the medical workforce has become skewed towards specialists, placing the federal government priority for improved primary care measures at risk. The demand for specialist referrals and the fix at all costs expectation of patients and relatives comes at a high cost to the health budget, with societal implications for sustainable and equitable healthcare. Srivastava reinforces the concept that more isn't always better, with evidence from the Dartmouth Institute for Health Policy and Clinical Practice. Their 2009 project brief on healthcare spending, quality and outcomes in the US highlighted research results which were actually counterintuitive, showing that higher spending and volume of care does not produce better outcomes for patients. Additionally, a paradox of plenty was acknowledged, noting access was worse where there are more medical resources. Srivastava recommends that communication as a core clinical skill is vital and requires dedicated training. This view is gaining global support, and the author refers to a key study by Cancer Research UK published in The Lancet, which shows the efficacy of a communication skills training model by randomising 160 oncologists to 4 groups. Statistically significant improvement in communication was noted for doctors that were allocated to the communication training group. And a 12-month follow-up study by Fallowfield et al. In 2003 not only reported enduring impact, but that additional skills also became evident. Whilst training of medical students may seem an obvious strategy, the question is raised as to why communication is still not a core subject in all medical training when we have research showing its effectiveness. An interview with Dr. Jim Howe, a neurologist and educator in Melbourne's 3 universities involved in medical training, highlights that Australia still has a way to come in this area.
I'm afraid my experience in the last 10 years in Australia is that things here are not as far advanced as they are in the UK. 15 years ago, I became involved in communication and interviewing skills training at Leeds Medical School, and there the third year students get a whole Friday morning for 2 whole terms practicing interviewing skills with actors and the support of a tutor in groups of no larger than 6 students. I'm connected with 3 medical schools here in Melbourne, and of those, Deakin is the one that does the most and has the most skilled undergraduate training in interviewing skills. And they have videos, interactive videos.
In Victoria, the Australian Medical Association and the Department of Health and Human Services commissioned a survey in 2015 which provided insight into practising doctors' lack of knowledge of current legislation surrounding communication and end-of-life care issues. They've responded to a need for education and developed an online resource for doctors, Advanced Care Planning, Have the Conversation, to support communication, engage patients in decisions about their care and help them to undertake advanced care planning. The Advanced Care Planning Australia website, supported by the Commonwealth Department of Health, provides a host of multilingual resources for professionals and the public. At a more international level, What Matters to You is an NHS Scotland hospital-based initiative that has been adopted by many other countries.
Do you see the difference? Do you know me a little bit more than you knew me before? That's what Matters to You is about. It's about compassion and care within our health system and our other systems.
After watching this thought-provoking TEDx presentation, Jason Leach, President of Scotland's Medical Association, inspired me to conduct my own survey of doctors and patients from my 2 polar workplaces. One, a 500-bed metropolitan acute private hospital, and the other, a government-funded statewide progressive neurological disease service. I devised a simple form asking the leading question, what matters to you? I surveyed 10 doctors and 6 patients. So what mattered to patients? Responses were similar across both settings. Being encouraged, presence of support networks such as family and friends, feeling happy, feeling empowered by being informed, having choices and a sense of control over their care and their day. What mattered to doctors? Responses ranged from the perfunctory ICU registrar's textbook biomedical model response, renal, heart, lung and liver function normalisation, to the jaded hospital physician's recognition of health inequalities. Whatever helps the patient, and if it costs the government money, bad luck. And the more patient-centred holistic approach of the neurologist working as part of a team. What matters to me is the team of professionals working to improve the person's quality of life and the quality of their family and carers, despite progressive neurological disease. Another of the respondents, Dr. Martin Jackson, an emergency medicine specialist and lead clinician for hospital and the home unit, reflected at how we can prevent outcomes like Mrs. Johnson's.
The ID physician wants to talk about her antibiotics, and the renal physician will only talk about her renal function. Cardiologist will only talk about her heart function, but there's nobody talking to Mrs. Johnson, nobody making the big decision.
One of the biggest challenges facing local and global healthcare delivery is an absence of compassion. Patient expectations and satisfaction with their health providers is low, and a shift towards patient-centred care is advocated by many, including myself. From a public health perspective, epidemiological data highlights the necessity of this shift. The World Health Organisation's statistical profile of Australia shows life expectancy is rising, burden of disease is increasing, and expenditure on health is rising. In treating an ageing population, the professional and ethical obligation for doctors to be involved in advanced care planning is paramount. The need to rethink healthcare is clear, and a shift towards social medicine in public health policy and practice has begun. There are many barriers to embracing communication skills as a core skill, traditionally seen as a supportive or counselling role. Entrenched attitudes and persistence of hierarchies within the medical profession are among the barriers described by Srivastava. There is no evidence that shows doctors don't value communication. There is, however, evidence that suggests doctors lack confidence in their ability to embark on difficult conversations. which is compounded by a lack of clarity about end-of-life care and the law surrounding these complex care issues, as outlined in the Department of Health and Human Services. In considering the ethical and professional balance of biomedicine, technology and social medicine, it is revealing to consider what your own expectations of healthcare are for yourself, your child, your mother, your father. As Jason Leach would say, if someone asked you, what matters to you, how would you answer?